Good morning. Sorry, good morning, everyone. I'm going to call the meeting to order. This is the Board of Health meeting, and our first item of business this morning is to approve the minutes from our last meeting, which was held 6 months ago on September 12th, 2017. The minutes include the stenographer's minutes, which are incomplete because the stenographer was delayed arrival, and some additional minutes that were provided by our department. I'd like to ask the board to approve these minutes in their entirety, both the minutes that we supplied and those supplied by the secretary. But first, can I hear if there are any corrections to the minutes? Dr. Foreman, welcome back. We missed you.
Thank you, Dr. Bassett. Yes, I was sorry to miss that meeting. I enjoyed reading the minutes that we did have, and maybe I'll just hand in, I found about 6, but I'm pretty sure are content errors. I said that instead of reading out to you all, I would just type up and I can give it to the stenographer. They're by page and line, and they're just content issues I think are pretty obvious.
Okay, thank you for, as ever, for your careful reading. Are there any other comments?
Just a small thing, but I think there's some inconsistency with titles of people who are speaking. Sometimes you've heard doctors referred to sometimes with Ms., sometimes with Doctor. Miss, M-I-S-S, was part of the minutes, should be Ms. I would just ask for a little consistency and accuracy on that.
Were those among your corrections?
No.
No. So going forward, will you supply those corrections?
I will supply them.
We will happily provide them to be included in corrections to the minutes. Are there any further comments or from the board? If not, may I have a motion to adopt the minutes? We have a second. All in favor, please say yes.
Yes.
So I take that as unanimous. The minutes are approved. This morning we have 2 items for the board's consideration that were previously approved for publication, and 3 items that are brought to you for consideration for approval for publication. We're going to begin with a notice of adoption to amend Article 11 and Article 13 of the New York City Health Code. Do we have a presentation? Dr. Daskalakis, can you state your name for the record and take us through the presentation?
Thank you. I'm Dimitri Daskalakis.
No, there we go. I'm Dimitri Daskalakis, Deputy Commissioner for Disease Control, New York City Department of Health. Good morning.
So thank you for your attention. Today we'll walk through proposals to amend Health Code Articles 11 and 13 for disease surveillance. So there are 2 areas that we're looking to amend. The first is Article 11 to require reporting of carbapenem-resistant Enterobacteriaceae infections. We'll call those CRE the rest of the time, just so I don't trip over Enterobacteriaceae. And we'll also present amending Article 13 to require laboratories to report all hepatitis B DNA test results, so all viral loads for hepatitis B. In terms of the rulemaking process, there we go. The Board of Health approved publication of proposed rules on September 12, 2017. There was a public hearing held on October 25, 2017. We received no comments regarding the CRE proposal, so no changes were made since we've heard no feedback. We received 2 written comments on the hepatitis B proposal, and based on those comments, we had made 1 change to the proposal. So first, we'll talk about carbapenem-resistant Enterobacteriaceae, or CRE, reporting. To remind you, CRE are a group of bacteria that are difficult to treat because they're resistant to many antibiotics. Infections that are caused by CRE are more frequently found in hospitals, nursing homes, and other healthcare settings. In 2015, there were over 1,700 cases of CRE infection in New York City reported to the CDC. CDC has in fact designated CRE as an urgent threat. That's the highest threat level in its list of antibiotic-resistant threats in the United States. This is just to impress upon you the very significant impact of this infection on human health. So to respond to that, mandatory reporting of CRE by laboratories is what we're requesting in this amendment. It will assist us in identification of resistant strains, clusters, and outbreaks of CRE, and also enable us, the health department, to ensure appropriate infection control precautions at healthcare facilities and provide appropriate technical assistance where necessary. Moving on to our second proposal, hepatitis B DNA test reporting. So we know that in New York City that there are about 100,000 New Yorkers living with chronic hepatitis B. Hep B can lead to serious health issues, including cirrhosis and liver cancer. Hepatitis B DNA tests are important in measuring amounts of virus in blood, or viral load, and they provide important information regarding infectiousness, treatment eligibility, risk for development of liver cancer, and also treatment outcomes. Our amendment that we're discussing today is amending the health code to require reporting of all hepatitis B DNA test results, including negatives and indeterminate results. So currently, we're only seeing positive results that are being reported, meaning we don't really have a denominator to our numerator. This enables the health department to identify gaps in access to care and develop targeted interventions to increase provider knowledge and linkage to care, to decrease HBV-related morbidity and mortality. I'll give you a summary of the two comments that we received. The first, from the blood center, requested that blood centers be exempt from the rule, noting that potentially hundreds of thousands of tests would need to be reported and that current reporting of positive results meets public health needs. So we agreed with this, and our response was that in the proposed amendment, we modified that to exempt blood bank laboratories and other laboratories that perform Hep B testing on donated blood from the requirement of reporting these negative and indeterminate Hep B DNA test results for such donated blood. The second comment we got was from a laboratory that provides end-stage renal disease that provides testing for end-stage renal disease patients, and they requested that such laboratories or end-stage renal disease patients be exempt from this reporting, and asserted that end-stage renal disease patients are in care, and thus public health rationale does not apply. So the lesson from other infections is just because you're in care doesn't mean that you're necessarily treated. And so we think that the end-stage renal disease patients with chronic Hep B should continue to be a part of this reporting structure, and that the reporting of negative results would allow us to better target strategies so that these individuals are actually not only in care, but are also accessing interventions that bring them to treatment as is necessary based on guidelines. That's the end of our presentation.
Thank you. Thank you, Dr. Daskalakis. The presentation is now open for questions and the proposal. Dr. Kritzman.
Thank you. I think this is an important step forward. I just had a question. What triggers CRE testing?
So usually if there is generally speaking, if there's a bacterium coming from a site that should be sterile, when that bacterium is growing in culture, the next response is to get susceptibility testing. So CRE, there's not well, it actually is a little bit of a specific CRE test, but it's really done in response to the pattern of resistance that you see in routine resistance testing. So if someone grows E. coli, and it's resistant to imipenem, which is a carbapenem, it then qualifies as being a CRE. So it's done on routine testing. So one of the things that will also be interesting in this, I think, as well, is that we don't really know the burden of this in outpatients. So I think that we'll also have a sense of what's going on with folks who, let's say, will have a urinary tract infection, they grow E. coli, and that will be able to actually see what the burden is sort of in the outpatient universe, as well as what we already know is a significant burden inpatient. There are some specific molecular tests that are done for carbapenem resistance as well, but usually having a sense of what's happening in the sort of standard antibiogram is good enough.
Thank you.
You're welcome.
Dr. Foreman.
Thank you. Just a quick question. I thought I understood it was the laboratories that would provide the results, both negative and positive here. So what is really the burden on a dialysis center?
Great question. So I think that the lab, I don't know the detail, and they do have a comment. I think that they're just concerned that there's going to be a lot of negative reporting. there may be, but I don't know what the burden really would be.
I think I can shed some light on this. So dialysis centers, when they have a patient new to them, routinely perform this testing because they do not want to contaminate their machines. And so there are machines that are designated for people who are positive and people who are negative. So they routinely do a lot of hepatitis testing. But I have to say, I do support the department's approach. I see a lot of patients in the emergency department with end-stage renal disease, and although they certainly are in care for their renal issues, many of them do seem to have gaps in care for other conditions. And it may be an important population to track exposures and treatments. But they do perform a large number of these tests on patients prior to dialysis.
Thank you. And again, the other
The other comment, thank you very much, it is electronic lab reporting, so the burden is, sort of illusory, like it happens sort of automatically for the most part, so I'm not sure where the complaint was, but I think the point of that population potentially being in care but not necessarily optimally treated is a really important one.
Dr. Foreman, did you have a follow-up question
No, I was
on
going
that, or a
to
separate
just
question?
agree with Dr. Richardson. My inclination is to support the department's proposal here, and I didn't understand what the burden was on a dialysis lab. I didn't think they were doing the reporting anyway. So, and it certainly seems like a population where there clearly are potential for significant gaps in care and treatment, so.
And additionally, they are patients who remain in care at that center, which is quite a different situation from a blood bank.
That's right.
Dr. Raju.
Again, thank you very much, nice to see you.
Nice to see you.
And I just need two clarifications. Right? CRE is basically a institution-focused disease. It's not a community-based disease. So,
As far as we know.
as far as you know, right? So the question is, if they are reporting these things to multiple agencies already, so adding one more agency to report to, how does it add value to us? And that's one question on that. On the hepatitis side, right, the fact we are going to exempt the blood banks, the blood collection agency doing that, what would be the negative impact on that? So would it send a different message to a different group of people, said you are exempted, you are not exempted? What is the rationale of exempting them and not the other folks?
So on the first issue of CRE, from the perspective of lab reporting, again, the burden is not very high on the lab. It would be electronically reported. We don't see where clusters are. We don't see where these infections are if we don't have that data. So, the CDC, though, they may see sort of a number of CRE infections. Like since we're on the ground as a local health department, we have a focus in our Bureau of Communicable Diseases on addressing antimicrobial resistance, and having a sense of where this is happening would allow us to focus our technical assistance and other work. So right now, we're sort of getting a number, an aggregate number, and saying it's about 1,700 CREs in New York City, but we don't know really the resolution that we would need for intervention. Does that make sense? The second question about why the blood banks should be exempt from this, I think it does have to do with the fact that it's hard to formulate a response, like some sort of some program or some kind of implementable intervention for people who are transient in and out of the service where they're donating blood. Versus if we have people who are linked to care, we're actually able to sort of identify where they are, and just like we're doing with HIV, potentially to come up with strategies to optimize the care where they are. We also think that in general for them, I think that the folks who will donate blood are going to be a little bit different than the folks that are going to be sort of connected to care, and we think that this the burden that they're describing, it's not worth their time and effort to sort of do this. So I think bottom line is that it's like the idea of where would you launch your intervention, and blood bank is like very transient, sort of people who are coming in not for testing but just for donating, and I think that we would be able to have a lot more efficacy sort of focused on sort of healthcare settings where people are getting viral infection.
Did you have a follow-up question, Dr. Raju?
So how, them not reporting, the blood donor size not reporting, what number of people we will not ever get to know that they have the hepatitis B?
Yeah, I can't estimate a number for that.
Would
we
there be
also have
substantial
precedent.
number we are missing because of that?
Still report positives.
Yeah.
Still report
Yeah.
positives. They report positives now.
Yeah, the positives will know it's been negative, so we won't have the denominator from them, so what will happen is we'll always get the positives. They just aren't gonna be reporting like the many negatives.
Right, I think that's just an important clarification for this conversation, is that the positives will still be
Yes,
reported.
From the blood bank, correct,
Their
nothing
concern
changes.
was reporting the thousands and thousands of negative
That's right.
results.
So we'll still know who's
So they will
there,
be exempted from the negative
Exactly.
reporting.
correct.
So to follow up on the issue with the blood banks, my understanding is that the reporting is electronic. So I'm still trying to grapple with the burden that we're placing. I understand the rationale, you're saying directing the efforts towards a population that has linkages with that facility so that we can follow up. You might not have those linkages with blood banks. But I'm still trying to understand the burden on the facility. If we come across this type of situation in the future, I think it'd be good to get clarity around that issue.
So I will just take that, we'll take that comment as one to follow up on. The truth is that, from the perspective of also volume of negative results coming into us from the perspective of data management, like a lot of negative results that aren't really in any direction won't be very helpful to us in general. So I think the sort of hearing that they don't really want to report, and then also know that the burden of those results coming to us would sort of further complicate our work. I think we're in agreement that it's okay that we don't get them, but comment is taken and we will explore that further. Thank you.
I think, yes, you're asking the question, Dr. Gatto, that what should we think about blood test results that come from blood banks? Are we ever interested in getting the whole population reported to us? You're asking us to consider what criteria we would use. So we will do that.
We will do that.
Dr. Foreman?
Just following up with that, as pointed out in the comment from the blood bank, you take this approach with hepatitis C, right? You don't get the negative results. They have an exemption
Right.
for that, and that has not been a problem.
That's correct. So we do have precedent for another hepatitis virus, hep C, that we do not get the negative results. It's internally consistent.
Thank you. Are there any other questions or comments? I'd like to thank Ms. Redlener for clarifying that this is really an addition of the reporting of negative results. It allows us to see the entire universe of testing. Well, if that, I'd like to thank the board for its comments and questions and ask that we take a vote. Can I have a motion and a second? All in favor, please say yes.
Yes.
Are there any abstentions or no votes? No, so the proposal to amend Health Code's Articles 11 and 13 passes unanimously. Thank you, Dr. Daskalakis.
Thank you.
Next item of business on the agenda is another proposal for consideration of adoption by the board. This one gained considerably more public attention than the previous one at both the public hearing and in terms of written comments. This is a proposal to amend Article 207 of the General Vital Statistics provisions regarding birth and death records. I know that you are well known to the board, but could you introduce yourselves? Dr. Schwartz.
Good morning. My name is Stephen Schwartz. I'm the New York City Registrar of Vital Statistics. Today we're going to discuss the proposed adoption of transferring records, birth and death records, to the New York City Department of Records and Information Services. We had proposed a fixed schedule to transfer birth and death records to DARUS annually. Prior to this proposal, there was no fixed schedule at all for records transfer. So we've been in business a long time, and for the last 200 years that I can remember, we did not have any fixed schedule for transferring records. It was episodic. So we thought it would be, the department thought it would be a good idea to actually have a fixed schedule. These records, of course, have interest, both of public health interest and also personal interest. And there are many people who are interested in genealogy as well. And so so what are these records? They are personal records for birth records, living people. So as a matter of public policy, these are private records, they are not public records. Private means only certain people can review those records. And so they include the demographic information, registrants' mothers and fathers' names, race, ancestry, education, dates of birth, addresses, birthplace, the confidential medical report of birth and confidential medical report of death, including cause and manner of death. So this is pretty personal information. We received a lot of comments. 31 people testified, 18 of whom also submitted written comments. We had over 5,000 written comments received, about over 3,800 of which were signatures to a petition, all of which were opposed to our proposal. There were only 2 commenters who were in favor of the department's report, and that was our professional association, NAFSIS, and the New York State Department of Health. So we listened very carefully and read the comments. Excuse me. We feel there is an opportunity to, in fact, expand access to records. We will discuss that in the next presentation in more detail. But to say that the department would like to propose an expansion of access to the records. So not the changes of dates. We had proposed 125 years for births and 75 years for deaths, but more to the point, who can have access to these records, these identifiable records. And so that's what we have, the coming attraction of the next presentation will be essentially proposing that we expand access to both birth records and death records for certain qualified applicants. So why do we propose this rule now? As I had said, we do not have a rule now for transferring records on a regular schedule. We wanted to conform to model state vital statistics law. We also wanted to ensure that no personally identifiable information of a person becomes public prior to a person's death. Right now, people are living longer. We like that part. We would also like to protect those records for as long as that person is alive. We also heard loudly and clearly that amateur and professional genealogists have expressed strong interest in accessing these records. So our proposed rule, to recap, is a birth record would become a public record on January 31st of the year following 125 years after the date of birth, and a death record would become a public record on January 31st of the year following 75 years after the death. That concludes my presentation.
Thank you. Should we go on to the next presentation? And who will be, and then we'll ask questions at the end. Are you going to continue with this presentation, or is there another person presenting?
Only me.
Only you. So we'll continue. Thank you. This presentation will address the ways in which the proposal has been amended in response to public comments. Or it's a completely different, it's a different change to the health code. Okay. Who can have access to, yes,
An expansion of access.
an expansion of access, and this was in response to public comment. Please proceed.
So we've already established that these birth and death records are protected from access to the general public because they contain individually identifiable information, which is considered private. However, they are also historical documents of interest to family members and persons researching their ancestries. So the department agrees that certain family members should have access to birth and death records prior to the records becoming public. So they're still private, but that entitled applicants, qualified applicants, could have access to them. The new proposed provisions will allow family members to access information while still protecting the confidentiality of vital records for appropriate periods of time. Currently, birth records are available upon request by the person of 18 years of age or older, by a parent or legal representative to whom the record of birth relates, by an attorney authorized in writing by the person of over 18 years of age, and upon an order of a court of competent jurisdiction. So those are for births. Current provisions for accessing death records include accessing by the spouse, domestic partner, parent, child, sibling, grandparent, grandchild of the decedent, a legal representative of the estate, a party with a demonstrated property right, a funeral director in the course of business, accessing that record within 12 months of death, and persons or agencies who otherwise establish that records are necessary or required for a judicial or other proper purpose. So let's move on now to what we are proposing, what we might call new and improved access to birth certificates with proof of death. So these are births where the department would,
Sorry.
so these are birth certificates where the department would require proof of death. And all of these were reporting as new. And I say that because we actually, as a matter of practice, been largely doing this. We want to establish this as a uniform practice under the health code. So all of these categories, spouse, domestic partner, parent of a child greater or equal to 18 years of age, a child, sibling, niece, nephew, aunt, uncle, grandchild, great-grandchild, grandniece, grandnephew, all of them we propose would have access to that record of birth if there's a proof of that death. And we are also proposing an expansion of those who have access to death certificates of a decedent. So the ones that are marked with an asterisk are new. So we are proposing to add, in addition to the spouse, domestic partner, parent, child, sibling, grandparent, grandchild, we're proposing to add great-grandchild, great-great-grandchild, nephew, niece, aunt, uncle, grandnephew, and grandniece. That is our proposal for your consideration.
Thank you. The proposal, both proposals can be considered jointly, I think, but we're going to have to take two votes. If I could just ask you to tell the board why 125 years was selected.
The 125 years is in the Model State Vital Statistics Act, so it is something that was voted on by all of the states. Since this is, vital records are a state function, so this was a collaboration of the National Center for Health Statistics and our professional association to come up with what was considered to be a reasonable way of protecting records and making them available after that time. 125 years, we have people who, we had a death a few years ago of a 118-year-old. We believe that that 118-year-old person has as much right as anyone else to have her record kept as private. So, as the population ages and as our New York City population grows stronger and healthier, that we would like to have all of those records protected. And we're hoping that 125 years is long enough.
Thank you. Open now for questions and comments.
Dr.
So,
Thank you, Dr. Schwartz. I had several questions, and the first one is, how do you think about step relations in this era of growing blended families?
Some people would ask that question. We do not permit that, and I'm not aware of any state that does.
Okay.
As a matter of practice and as a matter of proof, how do we actually operationalize that?
Okay. And then my next question is, how did you think about how many generations to go back? I was reading the comments where it seemed that some of the commenters were several generations removed, and I see in the case of great-grandchild, that's going 4 generations back. In the case of grandniece or nephew, that's going 3 generations back. So could you share with us how you thought about that issue?
Well, we looked at the comments, we considered them. It's also, how does somebody prove a relationship? We are essentially going to accept an applicant's representation. So we think this is long enough, that is enough generations, and for a purposeful use of this. And this will be subject to public comment, and we would learn from that and listen.
I just point out it was degrees of contiguity, I can't pronounce it, but contiguity. The other thing steps out. And also, at some point, they're going to become public to everyone at 125 years, so it wouldn't make sense to go.
Yeah. Thank you. And then just quickly, I just had 2 more quick questions. Can you speak about what the process would be for researchers or some of the categories who testify, professional genealogists, family genealogists, for obtaining records if they didn't fall into one of these categories?
We work with them all the time today, but the genealogist, him or herself, does not have an authority or a right to get the record, but they may hire somebody, that is, a family member may hire somebody to do it. So, and then they can authorize so that that family member will, who's a qualified applicant, can allow
That
the
would be the
access.
same as a qualified representative, is that correct?
They would have to have written authorization
Okay.
to, in the same way that an attorney would, where an attorney can act in someone's stead.
And my last question is, several of the commenters referred to other states that have, I guess, more liberal or shorter timeframes for releasing records. Can you share with us how you thought about coming up with these years? I know you referred to the model regulations, but I'm sure you also looked at other states that have shorter timeframes, and what was your thinking there?
There are still states that have open records, totally open records, where anybody can get anybody's record. Vermont just recently, I think in the last year, closed its records from, that was a completely open record state. So some of those, it's a challenge because we have 57 vital records jurisdictions, and they each have their own legislatures, as well as boards of health. And they make a decision, and sometimes that decision is not based on all the evidence. So we did a survey, we talked to people, we feel that what we've proposed is the right thing to do, and especially with providing greater access to the categories of entitled applicants, that will really make it work. And therefore keeping our records, our private records, private with greater access to authorized applicants.
Ms. Redlin?
Well, I must say that I was very impressed with the number of comments, both written and in person, and I learned a lot about this topic. So I have a couple of questions based on some of the comments that I think will add some clarity. The Model Vital Statistics Act, which you mentioned, I think was implemented or voted on in 2011. One of the individuals who commented said that act was put on hold in 2012 and not really implemented by any or many states at all. I'm just wondering about your perspective on that.
This may surprise people, but vital records to state legislatures is not always their highest priority. So it's not necessarily something that gets brought to the fore when there's a legislative session. And for most states, they are relying on state legislatures to pass these laws. We're really lucky because New York City has a Board of Health, which has enabled us in many ways to act very quickly because of the opportunity of having that board. So one thing is it's just not the highest priority in legislative agendas, and it's also a pretty long, the Model State Vital Statistics Act is some 70 pages, hard to get that through. One other thing came up with Model State Vital Statistics Act where It had been normally approved by the Secretary of HHS. In this case, it wasn't, and the stated reason was that they didn't want to address the transgender issue.
Okay, thank you. A couple of other questions, just for clarity. Also, another presenter mentioned that the U.S. Department of HHS in 2013 established 50 years as a post-death accessibility. Is that something that we're considering? Is that something is that true? I'm not, going by the folks who commented. That I was just
I'm not aware.
It's in the comments.
I'm not aware of that.
Okay, and then the last thing, because I'm really just trying to understand how New York City kind of fits within the country and the guidelines that are implemented. I don't necessarily think, from my perspective, that we need to be the strictest in the country. I think there are balancing factors to consider. And so I read in the initial proposal that you made in September, that we were also looking to be in alignment with New York State guidelines. But as I read the documents, I believe New York State recommends 75 years for birth records and 50 years for death records. Is that accurate?
Yes, it is.
So we're not proposing to be in alignment with New York State. We're proposing to be stricter than New York State at this point.
And our understanding in discussions with New York State, they are looking to be in alignment with New York City's proposal, though it has not been addressed yet.
And I think the other question, if I may, thank you, is just, I found it interesting, and I just don't know how to assess the accuracy of the presentations, but, from the various credible societies, representatives were saying that there really hasn't been much evidence of identity theft using birth and death records. That identity theft, is more, especially now in the age of the internet and cyber issues, there are other ways that people, are much more likely to get information about people that would, lend itself to identity theft. And, there was one chart that was entered into the testimony that showed, states how strict they were versus the number of identity thefts per 100,000 people, and it was a fairly straight line, whether you were strict or lenient. It didn't seem to affect the identity thefts that could be attributed to, birth and death records. Is that something that is your sense of information accurate?
I remember reading that too, and many people in the comments and in the public hearing, they raised the issue and said, make all records public, we don't care, it's already out there on the internet. Everybody can get everybody's record already. Well, I don't know how many people, if they were given the choice of having their records kept confidential or not, I'm not going to do a poll here, but how many people would really want to have their records completely open, including social security numbers?
Yeah, I don't think people are, at least certainly not all people are recommending just having records available. It's just a question of, the benefit and the risk and weighing the length of time that we are restricting records, which is, important for all these reasons. And I found it very interesting just to read about, how many people's ancestors came through New York City and, the records in our city relate to not just New York City residents, but immigrant populations around the country. So I do feel we have you know, a responsibility to consider the genealogical and the personal and the historical benefits to making some records available. I'm certainly not wanting to swing the pendulum to all records all the time. But from my perspective, I feel like protecting the 108-year-old by going to 125 years is too extreme. It seems that, you know, there are a number of states that either, you know, that recommend, you know, birth records being available at 75 and death records being available at 50 years, or maybe, you know, birth records 100 years. I'm just saying that from what I hear here, and I know it's a perspective that's from a genealogical perspective, that perhaps we are going a little too extreme in how we restrict the records. And I'm sorry, I have one more different question.
Okay,
then I'll-
and then we'll open it up for other comments from the board.
Just wondering.
These are all
how-
good questions, by the way.
Sorry. Just wondering how difficult it is and what the process would be for family members in your proposal to get information. You know, what is the process? You have to apply, you have to certify, how long does it take? Just wondering how that works now.
We're very fast, so people can walk into our office and walk out with a record same day. We can't do faster than that.
That's impressive. Thank you.
So, yeah, so we issue about 800,000 certified copies of birth and death records a year. That's the retail side of our business.
Dr. Foreman.
So, Dr. Schwartz, thank you very much. I was sorry to miss your presentation in reference to Alexander Hamilton last time, but I did read it. I also was fascinated by this topic, reading through all the comments and reading through the discussion last time. And I've been thinking about it a lot, and it seems to me that this is really an exercise in balancing the needs for access to this information between these authorized or appropriate individuals, which is family, versus non-family historians, genealogists and historians, who are not related to an individual who's trying to get that information. And on balance, it feels like this compromise, which expands fairly dramatically access to related individuals, is well thought out. I think this seems to really expand the access to many other people who may be related, although I had a specific comment about formal adoption, which I can come back to. But that seems to me to address many of the important concerns, leaving then the concerns about access to non-related individuals for historical purposes. And there was a big focus on, what are the downsides, and I read about the 3 states that were highlighted: California, who releases non-certified records, which doesn't seem to make much sense to me, and Vermont, which may have changed its rules, and Massachusetts. But it's not just identity theft. There are other misuses of that information that would not be captured in that sort of an analysis. I can think of employers, health insurers, lots of reasons why people might not want information contained in these records released that are not just identity theft. So as I've thought about it, I've come down a little more on the side of wanting to protect people's privacy, and less so on the value of genealogy to historians, which is the work of genealogists that's beyond what they do for an individual who's a qualified applicant. So overall, I think I support this compromise and the years that were proposed with a dramatic increase in access to individuals. So I just wanted to throw that out there. And then my specific question about adoption is, if 2 individuals formally adopt a child, will that person's children and grandchildren be captured by this? In other words, if I adopt somebody, and 50 years from now, will their children and grandchildren be eligible to apply for my information through the system?
That's a big question. the formal process that Vital Records engages in is that the original record, the original birth record is placed under seal, and the adoptive parents are placed on the new record. So that's the only information that we can provide.
I want to jump in here, though. The second proposal is being proposed for public comment. So adoption's an interesting issue that I think somebody raised steps earlier, and I think that those are things that we can hear comment on and consider before it's voted on.
I thought it was appropriate to discuss these together because they are linked. And in many ways, the proposal that we are being asked to consider for publication is the response to comments about access limitations that will develop because of the age limits, the years that are being proposed. It's the proposal on 125 years after birth and 75 years after death that we're going to ask you to take a vote on today. If I could just ask one clarifying question, are there any jurisdictions that use these types of age ranges, for example, that kind of age after birth for at 125 years after birth for access to a birth record? Are there any jurisdictions, or will we be the first?
Some states actually,
I mean, anywhere.
some states
Canada, for example.
do not open their records ever.
That's longer than 125 years. Dr. Foreman.
I'm sorry, thank you. I just had one other point to bring up, which is in the previous discussion last September in the comments. It was also noted that once the records are transferred to Doris, you no longer have the ability to modify them, which seemed to me to be important. And certainly, if you talk about an open record state where they're immediately transferred, that would seem very problematic, given the number of modifications you make to these records and how important that can be even many decades later. I think there was a description of an elderly individual who asked for his birth record modified, and it was a very important thing to that individual. Once it's released to Doris, you no longer have the ability to do that. And that is another compelling reason to consider maintaining the privacy and control of these records.
Dr. Raja, did you have a question then, Dr. Klitzman?
I concur with my colleagues that it makes very interesting reading, and I learned a lot about this by reading through these comments. In my opinion, it really falls into three different categories who really feel very nervous about this. The first is a group of people who are genuine family members who really want to know their ancestry, and they want to really find out what is about ancestry. Your proposal basically kind of gives them an opportunity to do that. That's not the issue with that. The second one is the commercial business interest. There are companies which basically do this research for you, and they would like to have an open way of doing that. And their core business model depends on having records open, so that they can really do that as part of it. I'm not very concerned about that. That's a business interest. So it's not really any particular individual interest. To me, individual interest definitely more important than the business interest of any group. The last one is a group which we need to address, but we don't yet. It's real researchers who really want to do some research into this document, and so that they contribute something to the scientific world which we learn from by the genealogy. We need to figure out how do we do that. It could be like we have the IRB in the things able to get some way of doing that, as opposed to do it. So I don't see a major issue with this, because I can see a tremendous amount of people are worried about things, but I believe that you do give them a really good opportunity if you're really interested in knowing your ancestry, then there is a method to do that. And if you really want to do research for the public good, then there must be a method to doing that. For the commercial interest of basically trying to do these things and make money, I really have no major interest to support that as an individual member. So that's my comment on this.
Thank you, Dr. Usher. Do you want to make a comment? And
I
hope
have
we're
a
heading
comment
towards
and
readiness
a
for
question really for my colleagues. And I also want to just appreciate all the work that you and your department have obviously put into this in considering all the comments and trying to respond in a way, to paraphrase Dr. Foreman, that balances the interests of privacy and public good, as we always try to do. My question for my colleagues is, given the interest that this has generated, given the nuances, do we feel like we can vote today on the first one before hearing comments and possible revisions to the second one?
The second vote would just be to post the proposal for public comment. And it obviously is then subject to revisions. Many of the questions addressed by the board are really considered in the public, as part of the public comment period.
That's the point, I
But
think.
we can, oh, I see. Oh, yes, please. Any comments, Dr. Foreman?
Yes. So my response to that would be that even setting a schedule of 75 years after death and 125 years after birth is an improvement from what we currently have, which is there is no schedule, right? There's absolutely no plan right now. So at the moment, nothing is moving unless you come to the board and say, we would like to, on this one-off, release certain records. So I would support voting on this today for approval because it is, although it is a step forward and at least sets a bar to move from. We could always, people could come back, you could come back and say, we've decided it's too long, we want to change it. But right now, there's no schedule at all. So this is at least sets a schedule. And I have confidence in the process of public comment and this board to then address in a mere 3 months the question of expanded access for people who really should have access.
I think is the question, just so I understand Dr. Crispin's comment, I think she's saying that if you're talking about these as a package, we should vote on them as a package. Is that basically your argument?
Yes, given the number and depth of comments on the first one, I'm just asking my colleagues whether it would make more sense to we hear comments on the second before voting on them. So again, I want to hear what my colleagues think, and based on that, possibly proposing voting on them together.
We've heard from Dr. Foreman, and he's prepared to vote on the 125-75.
I'm prepared to vote today. I appreciate the work on expanded access, and I look forward to the public comment on that. But I want to reemphasize Dr. Foreman's point that the situation right now is that there are records which I presume have, which are more than 125 years since birth and 75 years since death, which will not be released until we act on this. And so I'm not sure why those of you who are supporting more openness want to delay action on this one, pending a related but separate issue on expanded access to those who are related. So I'm prepared to vote, and I would favor voting now so that next time we can focus on the expansion for relatives as opposed to revisiting this entire conversation again.
I agree with both of them, so I am willing to vote on it today.
I would just like to note that the last time the records were released was 108 years ago for birth records and 68 years ago for death records. So we are under the threshold of what we're voting for, so we don't have to worry about not releasing, older records. But I feel,
That may be the release, but there may be records that were not released at that time, which now are over this limit. It's just a math issue.
I
think, I'm not quite sure, I'll look for guidance from the general counsel, but I think we better hear from everybody on whether or not they want to have a motion entertained.
I do
we
not,
have
I do
two
not want to vote
people-
on this without the amendment.
So we have a motion to.
Not yet, where we have Dr.
Yeah.
Raju to,
I am ready to vote on it.
okay,
am I.
all right,
I am as well, I'm ready to vote on
okay.
I am ready to vote.
All right, can I get some guidance from the general counsel? All right, then I'm gonna ask for a motion to vote on the amendment.
Move approval.
Then move for the approval of number 3, that's the notice of adoption to amend Article 207. This is the notice that was published in the city record on September 20th.
Move to approve.
All right, so let's have all in favor, say yes.
Yes.
Yes?
Yes.
All against? 1, and then any abstentions? 2, 1. All right, so the motion carries with 1 no vote and 1 abstention. The remainder are yes votes. Thank you. Okay, now we need to move on to the question of the proposed resolution to amend Article 207. This is the amendment that we devote most of our conversation to about extended access to birth and death records.
Move approval for publication.
A second? May I have all in favor, please say yes.
Yes.
All opposed? Any abstentions? This motion passes unanimously and is approved for publication. Thank you, Dr. Schwartz. We'll move on to item number 5 on the agenda, which is a proposed resolution to amend Article 43. These are school-based programs, regular school-based programs for children between the ages of 3 and 5. Do we have a presentation on this matter? Thank you. If you can identify yourself for the record. Please.
Good morning, I'm Corinne Schiff, Deputy Commissioner for Environmental Health, and I'm here with Dr. George Askew, Deputy Commissioner for Family and Child Health, and Monica Pollack, Acting Assistant Commissioner, Bureau of Child Care. We're here with proposals to amend Article 47 and Article 43. First, as a reminder, Article 47 covers center-based child care and shelter-based drop-off care, and Article 43 addresses school-based programs for children ages 3 to 5. I'll start by going over the proposed amendments to Article 47. We're really proposing 4 categories of amendments. First, to clarify certain provisions, and we're doing this essentially to facilitate compliance by child care providers. Most of the changes are not substantive. We're adding some definitions, and we're proposing some language for specificity, and I'll review the notable proposed changes. Next, we have a proposal to require once daily toothbrushing, to require epinephrine auto-injectors on site, and to enhance training requirements. So first, some of the notable new definitions that we're proposing. We're proposing to add a definition for competent supervision, and that the definition is that it would require direct observation for children to be within a line of sight, and that supervision cannot be conducted by mechanical, audio, or video device. A teacher has to be physically present in the classroom. the teacher has to be near enough to respond to children when they need it, and that supervision takes into account a child's age, emotional, physical, and cognitive development. Next, we're proposing to add a definition for corporal punishment. Corporal punishment is already prohibited under Article 47. But there's no definition for that. We are proposing a definition here that tracks the New York State definition. I won't read you that long list, but those are all behaviors that are inappropriate for teachers to use with young children. We are proposing adding some additional detail in certain parts of the article. First, to make clear that the maximum number of children on the premises includes all children who are present, even if those children are not enrolled. So for example, if a teacher brings a neighbor's child or a grandchild to work that day, that child counts toward the maximum number of children. Next, we would make clear that the maximum group size per room means a room or a physically separated space.
Dr. Ask if you can identify yourself for the record.
Absolutely. I'm Dr. George Askew, the Deputy Commissioner for the Division of Family and Child Health. I want to thank you. I appreciate the opportunity to present something which, on the face of it, and no pun intended, seems rather simple and mundane, but in fact can be life-changing and even life-saving for children. So why toothbrushing mandate in child care? Tooth decay or caries is the most common chronic disease in childhood, and it is preventable, and relatively easily so with simple measures like toothbrushing. Having caries can lead to higher risk of developing additional caries, difficulty eating and speaking, hospitalizations and emergency room visits, greater risk for delayed physical growth and development, and clearly because you either can't eat well, or you're sick, or you miss time in school. The American Dental Association recommends brushing twice a day at the eruption of the first tooth, which is usually around 6 months. We know in the pediatric field it's called the first tooth, first year, and that's the time we're supposed to recommend children actually see the dentist for the first time, sometime in that period. The department's 2014 Child Dental Health Survey showed that at least 15% of children in New York City child care programs experience dental caries. The prevalence goes up to over 40% in third grade. This is about, it's compared to about 1/4 preschoolers nationally. Despite the established benefits of toothbrushing, the oral hygiene practices of young children in New York City remain inadequate. According to the same study, 40% of children aged 0 to 6 years old brush their teeth only once a day or less, and 45% of children ages 0 to 2 did not use fluoridated toothpaste. Our oral health program conducted a survey to determine risk and protective barriers to tooth decay among children in New York City group daycare centers with over 1,800 parents and caregivers, and 67 daycare centers reported risk and protective factors for tooth decay of their children and themselves. So we know this is an area where we can and should do more. And of course, it is impactful on changing behavior. Toothbrushing, as part of the requirements for the federal Head Start program, has led to children in New York City's early learn programs being 2.5 times more likely to brush twice per day than children in other programs. So this clearly sets children up for a lifetime of good oral health habits. The department is proposing to mandate that child care programs and family shelter-based child supervision programs assist children aged 2 or older with brushing their teeth at least once a day. We are proposing that they provide the child with individual labeled child-sized soft bristle toothbrushes, fluoridated toothpaste with the American Dental Association seal of approval. The staff must be trained in proper toothbrushing technique, demonstrate proper toothbrushing techniques to children, keep a log of the date and time and the staff lead on toothbrushing, rinse toothbrushes individually or enable children to rinse toothbrushes, and store the toothbrushes in a sanitary manner. As I mentioned, rinse underwater, store in open air, not touching or dripping on each other or touching any other surface. Parents may opt out of this mandate with a signed written request.
Next, the department is proposing a mandate regarding epinephrine auto-injectors. It's estimated that 4 to 6% of children nationally have a food allergy, and some of those food allergies are life-threatening. The epinephrine auto-injector is an easy-to-use, life-saving device, and although we don't have data, the department's experience teaches that some children with life-threatening food allergies may not have the auto-injector with them in childcare, and that some children have life-threatening food allergies that are identified for the first time in care. In 2016, New York State amended the public health law to allow a childcare provider, among other entities, to obtain a non-patient specific epinephrine auto-injector. And so this gives the opportunity to have life-saving medication available in childcare. So the proposed program is to require childcare providers to keep 2 non-expired auto-injectors on site. It comes really 2 to a package. The auto-injector would have to be stored so that it's inaccessible to children but readily accessible to staff in case of an emergency, and it has to be at the appropriate dose. There would need to be a staff person trained to use it on site whenever children are present. So we would leave it up to the program to determine how many people they need to train to meet that requirement. And the training has to be by a nationally recognized or New York State approved provider. Those are the elements of the training program, and that tracks the New York State public health law. The program would include in its safety plan, Article 47 already has a requirement for a safety plan, so this would update safety plan requirements to include details about storage, checking on the expiration of the auto-injector, and for training. And should there need to be an administration of the auto-injector, the rule would specify that after that administration there would need to be a call to 911, which follows the packaging instructions, but we wanted to emphasize that by placing that in the rule as well. There would need to be a notification to the parent or guardian immediately, entry into the medication log, and then notification to the department within 24 hours. Next, we are making some proposals regarding training. There are 3 areas of training proposals. One is to establish uniformity of training requirements. The code currently requires certain training for certain staff, and the proposed trainings all address what we see as fundamental competencies that are valuable for all staff. And expanding training promotes high quality, safe childcare, and creating uniformity recognizes that this is a relatively fluid workforce, and so as staff move from one program to another, it promotes compliance if everyone has gone through the same training. The addition of certain trainings would be to fulfill professional development gaps that we see in the code, and also to align with new federal child care development block grant requirements. Those apply to federally funded programs, but they also suggest a baseline appropriate standards for all child care programs. There are a couple of trainings we are proposing to require be fulfilled sooner upon hire, and I wanted to note before I get to the details that the trainings are readily available. So first, the trainings for uniformity. I won't go through all of these. You can see them here, and they were in the proposal, but these were trainings that are currently required only for assistant teachers. You can see that they're really fundamental for caring for young children. Next, the board required in September certain trainings for shelter-based staff. We think these are important trainings for all child care staff. And then there are trainings that are currently required only for night staff or infant toddler programs that we suggest are appropriate for everybody. There are a couple of additional trainings that we're proposing. First is enhancement of the emergency preparedness, and that would be relating to natural disasters and violent events. And then also training regarding allergic reactions. So the scheme would be that everybody in the child care program would be trained in allergic reactions, and then select staff would be trained specifically on the administration of the epinephrine auto-injector. Regarding CPR and first aid, the Article 47 already requires that there be at least one person trained and certified on site whenever children are present. we would update that requirement to say that the training and certification should be in pediatric CPR and first aid and should have a hands-on component. We would propose to apply that to new and renewal permits. So that would kind of roll out. And then, as I mentioned earlier, we are proposing to change some timing requirements right now. The timing for child abuse and maltreatment is that a staff person needs to be trained within the first 6 months of the start date. We think this is a very important training and want to move the timing up to 3 months. And infection control and emergency procedures we think are also fundamental trainings. There's no specified timeline, and so we would make those within 3 months of the start date. And we would make clear, again, recognizing the fluidity in the workforce, that the training is transferable from one program to the next. And then we made some proposed adjustments. The board in September added provisions for shelter-based drop-off care, and you may recall there was discussion about accreditation and that we had not been consistent in the proposal at that time, and so we have updated the language, we think, to address the concerns that were raised by the board at that time. In the September meeting, you asked us to get back to you with an update, and so I'm happy to report that out of the 33 possible drop-off sites, 25 are already in the permitting process. 5 had no secondary egress, so those are not eligible. 3 didn't apply, and there are 3 additional sites under construction, hoping to become drop-off sites. That is it. And so that was addressing Article 47. The main proposals are the same for Article 43. The proposal to add the once daily toothbrushing, maintenance of an epinephrine auto-injector, and the training requirements. And we can take questions.
Thank you to the presenters. So this is a fairly expansive addressing of Articles 43 and 47. Let's try and keep the conversation orderly by talking about it in the order that it was presented to us. The first were the clarifications to facilitate compliance, things about line of sight, supervision, and so on. Are there any comments or questions about that?
I just think generally that the safety, health, and well-being consistency is much appreciated. And also want to acknowledge the fact that there will be shifts in the administration of childcare in the city now. And so it's useful to have consistency across programs as the childcare programs move from ACS to the Department of Education. So I appreciate these very much.
Okay, thank you. And then shall we move on to a discussion of toothbrushing, or did you have a comment?
One comment. These training requirements are ongoing, or is it just once you get trained and that's it, you can keep it for life?
Well, that was the fourth part of the presentation.
Oh,
so
okay.
Can we just see if anybody has any comments on toothbrushing? Dr. Foreman. I saw a lot of hands up. So. Dr. Foreman.
So, thank you. This is an interesting proposal. I certainly agree with the importance of dental hygiene prevention of caries as a critical public health issue for young kids, without a doubt. But I am struck by the potential challenges logistically of implementing this. I'm just imagining these preschool classrooms with kids and toothbrushes and water, and having worked with young kids a lot, it seems challenging. And I'm sure a lot of this will be discussed when this is published for comment, and presumably we approve it, and there's a lot of comment. But I wanted to ask about the New York City early learning programs that were mentioned, which seem to imply that this is successfully implemented in a certain category of early childhood education programs that are under federal regulation that asks for this. So I just wanted to hear does it work? Is there a model for making this work? I can just imagine kids sharing toothbrushes and all the other risks that come with it.
Absolutely, it works, and it works quite well, and it's been working for many years. I was actually the pediatrician for the Head Start program back in 2000, and it was already being implemented then as part of the program standards for Head Start. We actually went out, we visited programs that do the practice. It's very simple. It's not very burdensome. It takes 10 minutes or less. from actually going from getting the toothbrushes together, getting the toothbrushes loaded with toothpaste, brushing the teeth, and then back into their storage area. So it's much simpler than you might imagine.
And there's a lot of those programs, right?
And there's a lot of those programs.
That's reassuring.
Well, Head Start serves about 1 million kids across the country.
Dr. Gallagher.
I want to thank you for that presentation and for your hard work. This is really, I think, fantastic to be in a Department of Health that's doing this great work. So my questions were also about the logistical nature of the toothbrushing and the same concern about, do we have any guidelines to prevent sharing of toothbrushes, number one? And number two, what is known about the risks of communicable diseases? I know it's been established that this work has been done with over 1 million kids, as you mentioned. Has there been any research on what the risks are for communicable diseases if there is sharing of toothbrushes?
As part of the mandate, each child will have to have their own toothbrush that will be labeled for each child. From what I understand and know, that the sharing of toothbrushes, once you've done that, is not much of a risk. With respect to communicable diseases, I have not seen any published data around communicable diseases being spread through toothbrushing practices, but that's just to say that I'm not aware of it. It may be in fact true, and I'll actually, if my
We haven't come across any literature on communicable diseases related to this.
Do I need to ask you to identify yourself for the record?
I'm Talia Rubin, dentist here at the Department of Health.
Thank you.
I want to thank you. It'd be nice when you come back to the board to present those data to us.
Great,
if you do have them.
Absolutely.
And Dr. Richardson.
Yeah, again, echoing my colleagues, thank you all. The standardization and consistency you're proposing, I think, really is a huge step forward. I guess I want to probe a little bit more. I am reassured to hear about these Head Start programs, but this has been done successfully. One of my major questions was about the length of time this would take. I'm the mother of two, and I couldn't get the two of them with, their teeth brushed in 10 minutes. So is there some differences in the staffing ratios in the Head Start programs you're describing and what's typical in child care centers? Because I can see this becoming, in addition to the concerns about sharing of toothbrushes, quite an onerous process that takes up some portion of the day that might better be served. It's been my observation that not all 2-year-olds enjoy having their teeth brushed, and so I do think there are some trade-offs to proposing this, and I understand all of the benefits, but I guess I'd like to hear a little bit more about reassurances that this isn't going to become
It's like anything else that you're introducing to infants and toddlers, right? That is a challenging age. But what we find with toothbrushing is that this is actually a wonderful transition activity in childcare as well. So you can combine it with a singing activity. You can make it part of a transition. You can use it. So again, it's opportunity. It actually provides an opportunity for the providers. One of the things that's very difficult in child care programs is transitional activities, and this is a wonderful one that actually serves a very important purpose.
Thank you. I think Ms. Bedlener, please.
Thank you. I certainly.
I know you like to.
I certainly endorse the early introduction and consistency of toothbrushing in children, and interesting to see that it has long-term effects. My one question is engaging parents, or somehow incorporating, making sure that parents are aware that this is a process that they can do at home, that it's not just the responsibility of the child care facility, that that they should be aware of the goals and the reasons for why we're doing it, just like a little parent education complement to the new activity.
Absolutely, and I'm sure that'll come through in our guidelines. And clearly, toothbrushing in childcare leads to greater toothbrushing at home, because if you're only doing it once, but you're also seeing that more of those children are having their teeth brushed 2 times or more throughout the day, clearly means that parents are getting the message, or maybe kids are even asking for them to have their teeth brushed.
Great, thank you.
So perhaps the last comment from Dr. Klitzman.
Thank you. I'm sure my dentist is very appreciative, as my teeth are probably the most expensive part of my body besides. Anyway, thank you for your excellent work. My question is, have you yet, or what are your plans to engage the regulated community daycare center, childcare center operators in figuring out the best way to address some of the implementation issues that have been raised?
First, should the board approve, the proposal would be open for comment, so we will hear from the providers. The department will be providing training, and we will be putting out guidance for them and can make recommendations about when they might think about including it in the course of the day, when it might be a little less time consuming. Children are already sitting around the table eating lunch. That might be the time to then pass around the plates with a little bit of toothpaste and brush right there. So we can make those suggestions. Ultimately, it's up to the program. We are not proposing to dictate when it would be. And so every program is going to be different, and it'll be up to them to figure out the best time.
Thank you. The next item to discuss is the proposed requirement for epinephrine auto-injectors to be on site. Are there any questions or comments from the board? Dr. Foreman, Dr. Richardson?
So thank you. Just a very quick one, which is, are there other jurisdictions that require this, and actually 2, and how has it gone with them? And the second is, what does the Quad AI say about this? Do they have a position on this? The American Academy of Asthma, Allergy, and Immunology is Quad AI.
Our research revealed no other jurisdictions with a mandate for childcare, and we will send the proposal to that professional organization to get their feedback.
It seems to be the professional organization for allergists and immunologists, and that's where this sort of stuff is often discussed at national meetings.
Great. Thank you for that comment. Thank you. And Dr. Richardson, and then Redmond.
Yes, as an emergency physician, I'd really like to applaud your attention to this detail. Anaphylaxis does claim a number of lives, and this is a potentially life-saving intervention. These are, and this has been the subject of a lot of news, expensive items, though I think the cost-benefit ratio certainly favors doing this. I was struck by the last provision in this section regarding training by a state-approved or nationally recognized provider. I assume you have some examples of this. I hope that this is not overly burdensome. I routinely teach people to use these injectors upon discharge from the emergency department, so I'm not sure what these programs are or what they represent, but I just want to make sure that we're not creating unnecessarily burdensome training for what really is quite a simple procedure.
So the state public health law requires exactly what we have proposed here, which is that there has to be, for a non-patient specific auto-injector, in order to have and maintain one and use one, you need to have a training by a nationally recognized organization or a New York State approved provider. We will provide guidance about those trainers. I imagine that it's possible that should this go into effect, more trainers will appear. We have found at least one trainer that provides an online training that is 45 minutes and $25.
45 minutes?
So that's what's available so far. Perhaps market forces will develop additional trainings that would be approved.
Thank you. Ms. Redlund.
I think this is a very important proposal. I'm just wondering what the regulation is for schools in general. This is for daycare and early
childcare, but do public schools have the same requirement?
Very similar, I just want to make sure I don't get it wrong, but it's very similar requirements in schools already.
Already. Thank you.
And Dr. Carroll, and I believe, and I hope I haven't gotten this wrong, that about half of the administered epinephrine in schools to children who didn't have documented allergy.
I'm just wondering, the dose for adults and children is not the same. Then, and for children, the age is very important. That can be in the implementation phase in a given setting worry me.
I think the question is, have we looked into having the correct injector?
So currently, the auto-injector comes essentially in young children and older children and adults. There is another pharmaceutical company has FDA approval to market an auto-injector for babies and toddlers that will be on the market by the end of the calendar year. And so our guidance, and that may be why the training is a little bit longer, because there's an issue about dose. So our guidance will make clear, and childcare programs, as you may know, are permitted based on the age of the children. So there are programs that are defined as infant and toddler programs, so they would be, and the weight of the children there, as a general matter, aligns with the new auto-injector that will be available for very young children, and then we have programs for preschoolers, and so that child-based auto-injector would be appropriate.
Great. Were there other questions or comments? If not, let's move on to the training component. And Dr. Raju, you had a question on the training requirement.
My comment is that, is it a one-time training, or is it a kind of a refresher courses being offered?
Different trainings are for different periods of time, so many of the trainings are one time. There are some trainings that are every 2 years, so the CPR certification is something we need to renew every 2 years. And again, where we do not say the time frame in the proposal, that is one time, otherwise we specify when it needs to be taken again. And in our guidance, we would set that out in a way that would be clear for the providers, so they will know exactly how frequently staff need to be trained.
Does the training is purely, does it also include competency demonstration component for the training, or it just purely you take the slides and you sit through the courses?
It depends on the training. Some of them, so to get CPR certification, there's a test you need to take, and others are a video that you watch and probably get a certificate at the end, but there may or may not be a test. Mine. Test. So some have tests and some don't.
Dr. Foreman. Pardon, Dr. Foreman.
Thank you. I just had a quick clarification. Something at the end there said a requirement for pediatric CPR and first aid. I'm only aware of a standard CPR course that includes children and adults. I'm not aware of a separate pediatric CPR course. And then I wondered what exactly you're referring to for pediatric first aid. Is that some sort of a separate training?
So if the class addresses both, it wouldn't need to be something that's specifically labeled pediatric CPR and first aid, but we wanted to make sure, and that is also something that is highlighted in the new Child Care Development Block Grant requirements, that the class includes a pediatric component.
So standard CPR training, American Red Cross does include that. You're tested on mannequins that are infant, child, and adult. So it does. I mean, never seen one that doesn't.
I've seen lots of adult-only CPR classes, and so it has to include the pediatric component.
This reflects my biased experience as a pediatrician. I never take a course that doesn't have kid teaching in it.
Thank you. Are there any other questions or comments? On this, I believe we again have to take two votes separately for Article 43 and Article 47. Let's take the vote first on the proposed resolution to amend Article 43. Again, you're being asked to approve these for publication for public comment. May I have a motion?
Second.
Thank you, and a second. All in favor, please say yes.
Yes.
Any noes or abstentions? Thank you. The motion passes unanimously. And the next is the proposed resolution to amend Article 47. This had some additional components you recall we went over this morning. May I have a motion to approve this for publication?
So moved.
And a second, and all in favor, please say yes.
Yes.
Good. The motion passes unanimously. Thank you very much. We had two presentations planned this morning, but I think we had a robust discussion and we may not have time for both presentations. The first one was a presentation to update you on seasonal flu. And because that will be irrelevant come June, I suggest that we start with that presentation. Dr. Daskalakis. The flu season ends officially at the end of May, but who knows with climate change what will happen.
S-K-A-L-A-K-I-S. So thankfully, we will hopefully be irrelevant by June. So I'll give you the update on really influenza activity as well as, I should probably say my name again, Dimitri Daskalakis, the Deputy Commissioner for Disease Control for the record. I will give you an update on influenza activity for this year as well as our activities around vaccination as well as details of vaccine efficacy. So just to remind you, if you are in healthcare, you are aware of this already, that this was a very active non-pandemic influenza season, the most since 2003, 2004. This season, the circulating virus was dominated by H3N2, which is known to generally cause more severe disease than other influenza viruses and also have some issues with development of vaccine as it passes through egg. We have seen increased numbers of outpatient visits, hospitalizations, deaths, and institutional outbreaks. It is a typical season in that this is most severe in the elderly, but also a bit atypical because we saw that the most affected other than the elderly were middle-aged adults, actually more than young children. This is a graph that shows New York City laboratory surveillance of influenza. So I will walk you through this quickly. So it's the percentage, the number and percentage of flu swabs that are positive for influenza as well as actually RSV we're showing as well. So you'll see first the bars, and I don't think it is sort of working here. You'll see the bars. The majority of activity that we've seen so far this year has been flu A, although we have seen flu B. This blue line represents the percent positive swabs for influenza in this season. So you'll see that compared to prior seasons, which is 2016, 2017, we have a lot of positivity. So this peaked February 10th with 35% of our specimens positive for flu. So that is a lot of flu. Notably, RSV really mirrored last year. So not a lot of increase in RSV activity. So a lot of influenza A, some influenza B, and a lot more than last year. So a very active flu season from the perspective of lab surveillance. Moving away from lab surveillance and looking at surveillance of influenza-like illness visits to emergency departments, in this condensed graph, you'll see time from 2001 to 2018. This is the 2003-2004 Fujian season that was, if you recall, was a terrible flu season. You'll see that the peak of influenza-like illness visits to emergency departments was high, but not quite as high as 2003. About 8.9% of visits at the peak of the season were due to influenza-like illness, which I see that you're nodding. So there were a lot of flu visits and a lot of activity. Another way of looking at this, and I think this is an interesting way of looking, also maybe commenting on the fact that we've seen less ED visits. You also see that outpatient visits in non-ED settings are also up and significantly up from prior years. So that red line represents visits to outpatient venues 2017 to 18. And when you compare that to last year, which is the blue line, you'll see that there was a lot of activity with folks going to outpatient venues, which may also include urgent cares. So we have a lot of folks pursuing care. We do have data showing US hospitalizations. This is where we saw a little bit of a difference in trend. So though the colors are hard to see, the curve that you see here is among elderly patients. Usually the next curve that you would see are youth, but in this year we're actually seeing middle age showing increased activity, and so that is 50 to 64-year-olds, and that is in pink, which you can see is the second curve. So following them are the 0 to 4-year-olds, so a little bit different. We may have a couple of hypotheses for why that is, but definitely a lot of influenza hospitalization happened this year compared to prior non-pandemic years. Also, from the perspective of pediatric deaths, the country had 97 deaths in the United States so far. In New York City, we have had 4 pediatric deaths. This is not above average. We tend to see 0 to 8 deaths since we've been looking into since 2004. And again, this season seems to be more severe among elderly and middle-aged adults than it was among children. So again, there may be some ideas where we talk a little bit about vaccine efficacy when we get to that part of this presentation. You'll also note that there were increased numbers of outbreaks reported to us in long-term care facilities. It's important to note that our methodology for measuring these changed in 2013. So though these are interesting bars for the picture, I would really focus on 2013 on when you're looking at these outbreaks in long-term care facilities. So it's notable that in this flu season, we had many, many reports. So we're not out of the season yet, so we may still have more to come, but a lot of activity in long-term care facilities. So we continue to do a lot of work to promote influenza vaccination throughout the jurisdiction. So some of our routine work was our sort of normal kickoff event with Dr. Bassett giving the mayor his flu shot. So thanks, Dr. Bassett, for doing that very public, important demonstration of the importance of influenza vaccination. We had a citywide influenza media campaign, and I will show you that in a moment. There were ads in subway stations, subway cars, and bus stations, as well as a lot of digital social media on Facebook and Twitter, as well as Instagram. We continue to distribute vaccines for children through the VFC program. We give pediatric care providers a report card of how they're doing from the perspective of coverage of flu vaccine and practices. We issue health alerts, provider letters. We continue to make it very easy to find flu vaccines. So pretty much in New York City, anywhere you turn, you'll trip over it. And if you don't know where to find it, you can go to our vaccine locator on our website or call 311 or text 877-877, either flu or prepay, to find out where you can get your shot. So we have a lot of ways to help people localize flu vaccines. So this is an example of our citywide flu media campaign. We got our flu shots, not the flu. And so these ads were throughout the city, both in English and in Spanish. We also had some specific response based on the severity of this influenza season. The first is that we provided a lot of technical support to pharmacies to support the Governor Cuomo's executive order that allowed them to vaccinate children aged 2 to 17 in those pharmacies. We partnered with Walgreens to provide 1,000 vouchers to uninsured and underinsured adults and children ages greater than or equal to 7 years of age. So that age cutoff is important because that's when those pharmacies actually allow vaccination. So under 7, they do not vaccinate. There are some pharmacies that do, but Walgreens we do not. We participated in Flu Phone Bank with Telemundo and NBC. We distributed more vaccine for children to meet the demand. We also sent a letter to providers and asked that their VFC providers to waive the administration fee during this emergency time. So we're not able to measure that and say how many providers did it, but we did ask for them to take this step. And we partnered with our Office of School Health to promote flu vaccination in our school-based health centers. So in terms of what we've seen this season,
Flu vaccination rates did increase for children and adolescents, and actually, most of that increase was in response to the emergency order, so it was an effective public comment to pursue that and support the governor's order. Flu vaccinations have already surpassed last year's, so it's 45.7 compared to 45.4% at the end of last flu season, and we expect this to increase a little more, but we've definitely seen a drop off in vaccination that goes along with the thankful drop off in influenza activity. In terms of flu vaccines given to children and adolescents, you'll see that the majority of vaccines were given in the fall, which is our ideal when early in the season. But you'll note that that really the bars for this year, so the yellow, the gold bars versus I think they project as purple, but they look blue on my screen. So the blue or purple bars, depending on where you're looking, represent last season. We definitely see increased flu vaccination compared to last year. In fact, about 104,000 more doses were given this year compared to this time last year. And something that we think is really important, I think this graph is one of my favorites that we're presenting in terms of influenza vaccination activity, is what happens with the executive order. So when pharmacies were allowed to give vaccines to folks that were younger, we actually saw really significant increases in immunization both among patients 18 plus and less than 18 years of age. So the real message I think there is that pharmacies are a very great place for folks to access influenza vaccine. And so the other wonderful thing about this is to show you that this is this year's executive order. That was on January 25th, 2018. And when you compare that to the executive order in 2013, we really got a lot of traction out of the order that happened this year. So I think that the message was really clear. To combine our messaging as well as other messaging, I think was really effective in getting folks vaccinated. Still though, when you look at pharmacy vaccination among children, about 85% of the vaccine was given to children 7 years or older. And so again, that is both partially because of unwillingness of parents to bring children to pharmacies, children under 7 to pharmacies for vaccination, and some of the limits set by pharmacies. So some places would vaccinate under 7, some don't. So that may be a little bit of a manifestation of that difference. And then finally, the last thing I want to talk about before I take questions is just to talk a little bit about vaccine effectiveness and what we've seen sort of in the interim vaccine effectiveness analysis done by the CDC. So overall, the interim vaccine effectiveness is thought to be 36%. For the more commonly circulating strain, H3N2, it's 25% for all comers. For H1N1, about 67%. And for flu B, 42%. So not bad, better than expected, and compared to some of the media that early on in the season was misreporting our vaccine efficacy to be 15% based on data from Canada and Australia, really demonstrates that vaccine efficacy is very geographic and that you can't extrapolate vaccine efficacy from other jurisdictions into your jurisdiction. The other example being that when Australia had a 50% vaccine efficacy, New Zealand had a much higher vaccine efficacy than their neighbors. And then finally, potentially one of the reasons that we saw better results in children than in adults is that the vaccine looks like it worked better in kids. So the efficacy approached 59% for children, 6 months to 8 years, while it was significantly lower in adults. So there are a lot of reasons why this could be, but bottom line is that vaccine works, and remember, vaccine efficacy measures prevention of flu. The people who get the vaccine are less likely to be hospitalized, get pneumonia, and have other complications, and that is unmeasured in vaccine efficacy. Thank you.
Thanks. Any questions or comments? I should point out that the state is bringing legislation to codify the pharmacy vaccinations of children over 2, which we are in support of and have been in support of for some time. So it's still not too late to get a flu shot. I should end with that comment, and thank you very much for a very thorough presentation. Thank you. Well, we have 10 minutes remaining, and I really think we should just call it a day. I want to apologize to Dr. Maybank, who I want to thank for being present to give a presentation on something that's a very high priority for me reviewing our strategy for neighborhood health and the promotion of health equity across our city. So we will table that one and have the presentation at a later date. With that, I'd like to adjourn the meeting. Thank you all.